can't see you.
No, they can't. Why did it take 50 years? And it really relates to politics. Well, what are the politics of stewardship? They're complicated. It includes government structure, the role of crises, the role of media, the culture of a country, inertia, fear of change, lobbying, international responsibilities, the trading relationships, stakeholder buy-in or otherwise, and the healthcare systems. And I'll just illustrate that by the story of, of Holland, which had a perfect storm about 10 years ago or so. I think one of the drivers was that farmers, veterinarians, farm families were turning up to hospitals being tested for MRSA because the Dutch have got a search and destroy relationship with MRSA, and these people were all positive. So that was a huge, what the heck's going on there at a time when the Dutch knew that they were the lowest users of antibiotics in medicine in Europe, but among the highest users of antibiotics in agriculture. At the same time, Q fever was affecting thousands and thousands of Dutch people with serious illness. They became aware that chicken E. coli, which were ESBL, were getting into humans and causing disease, and there was an absolute media firestorm around it. It was an existential crisis for agriculture. And they had the Dutch Minister of Agriculture pinned to the wall of Parliament by the Greens, and in order to get away from the scrum, she blurted out, "We're going to reduce antibiotic use in food animals by 50% over the next 3 years." Her staff said, "What? Where did that come from?" But they've actually reduced it by 70% over about 8 years. And in Canada, what we've always said is, how are we going to get people to take this stuff seriously? And we've concluded in the agriculture world that maybe we need a disaster. But we don't want a disaster. But this was the Dutch disaster, which resulted in major changes. There's always a political moment where you can move, and this was the Dutch political moment. And you can see from that slide I showed earlier the boxes which are being ticked in Holland, the culture of the country. The Dutch are the Dutch. When they do things really, really well. And you could tick in North America, United States and Canada, the other boxes to explain why it took 50 years. The changes in agricultural use in the United States and Canada, this kind of swan plus 50, were driven really, I think, by, it couldn't stop it anymore. The pressure, the political pressure globally was so great, nationally was so great, that something had to give. And I think it was Obama particularly who drove it to say we need to change what's going on in the agricultural world. It was so pushed by media and constant media stories. The NGOs were heavily involved. So it was no longer feasible to stop the way we would, or change the way we were using antibiotics in agriculture. And it sort of moved almost into a farce where it became a kind of a joke. And so that was the reasons for change and political change. The other sort of, I think, political thing I should mention is the O'Neill report, where a blue ribbon committee led by Lord O'Neill in the UK looked into this issue really deeply and said, look, by 2050, the loss in global productivity is going to be $100 trillion, and there's going to be 10 million people dying every year. And this is going to exceed any other major cause of death globally. This is absolutely brilliant politics. This is British politics at its best. Here is an economist, a businessman, a very practical person who's not the medical establishment. He's an outsider taking a look at AMR and how the heck did we get where we are. And linked in heavily to the British government, part of the political process, discussed in Parliament, a fabulous roadmap to the future, a global view of AMR and what needs to be done to turn the ship. I think some of the numbers are dubious. I'm not sure the evidence-based for some of the numbers are correct. Making it 2050 makes it really big numbers, but this is brilliant politics. It's caught global attention in a way that maybe a lot of other things haven't. So that's some of the politics of AMR. What about One Health? One Health's getting a lot of attention globally. It's been the way that we're thinking about agricultural use and maybe use generally of antibiotics, and it's been a very important development for, I think, reasons I'll explain. What is One Health? It's an interesting history. It's a complex and I think sometimes evolving concept still. It means different things to different people. Vets and environmental scientists like it a lot more than medicine. And basically what it is, it's a holistic view and a collaborative effort of multiple disciplines, working locally, nationally, globally, to obtain optimal health for people, animals, and the environment. One Health problems are what we call wicked problems. Wicked problems are problems that are so complex that no one individual group or discipline can completely understand them. They demand action. Living and working in silos, as we've done for so long, doesn't solve wicked problems. Solutions require very comprehensive and interdisciplinary strategy. This is a slide we use a lot in Canada, and I think it's gone around the world. It's originally from Britain, to try to describe the epidemiology of resistance. It used to be a slide which just shuts conferences down because it's sort of too complicated, but I'll describe what it tries to show is kind of a One Health approach to things. That in human medicine, antibiotic-resistant bacteria kind of evolve in hospitals and other places. They're driven by antibiotic use, and to some extent, it's a self-contained ecosystem. The same is true of farms. There's different use of antibiotics on farms, different drivers, different quantities of antibiotics used in different purposes, and to some extent, it's an independent, sort of self-sustaining ecosystem. However, there's crossover from food animals through the food chain into people. There's crossover through effluent. There's crossover through water. There's crossover in other ways, and the same is true in human medicine. As antibiotic-resistant bacteria get into sewage, untreated sewage around the world, even treated sewage. They get into drinking water. They get into wildlife, are distributed further in wildlife, and companion animals sort of link humans and animals very well. I'm sure it's much more complicated than that, but that's a kind of a general kind of summary of kind of One Health: animal health, human health, environmental health, or environmental linkages. So will One Health save us? I think the really profound value of One Health is that it's moved us from blaming to action. That we no longer sort of point fingers at people. We say, look, we need to take a One Health approach where we limit adversarial responses. We try to motivate everybody using antibiotics to do better. We all accept responsibility for our piece of the corner that we're fighting in. It's globally exemplary, and it moves us to action. So I think that, to me, is the particular value of One Health, as well as trying to understand the linkages that there are, which I've tried to briefly describe. And I don't know if you get it, but One Health is a political concept. Like One Health is a political idea, and I think this truce through One Health it will only be temporary if effective action is not taken. I think that's a really important concept. But currently, One Health works. It's got people rolling their sleeves up. It's got people moving. It's got people not pointing. It's got people out of the silos, talking to each other and realizing the scale of what's going on. So what are the challenges of antimicrobial stewardship? I probably don't need to tell this audience, but everybody talks about climate change and the similarities to the challenges of climate change. The challenges are immense. They're similar to climate change in their global nature, in their complexity, in their multiple dimensions. They differ from climate change in that actually most people actually believe that antimicrobial resistance is a problem. And secondly, that behavioral change can be shown and has been shown to have remarkable effects on reducing resistance. So that's, I think, the difference. I tried to sort of integrate what are the kind of One Health antimicrobial stewardship challenges. I think the biggest challenge is the rapid evolution and spread of resistance, the global scale of what we're dealing with. I think the ongoing challenges of leadership and coordination at different levels, motivation and commitment, the complexity of the delivery of stewardship across different fields, really not knowing quite how to measure success, the lack of data on the efficacy of different actions. Again, inertia, like 50 years in North America, it's not just the politics, but it's also inertia, pressures to prescribe, and so on. So these are some of the challenges or at a kind of One Health level of stewardship. When I talk to veterinary practitioners about stewardship, I say, look, it's got different elements. So it's got clinical practice guidelines, infection control elements, clinical microbiology, the use of this, surveillance of resistance and use, knowing how you actually use drugs properly based on their characteristics, regulations, education, and compliance. And so my question to you, because you've thought about this a lot, is which of these approaches is the best way to improve stewardship? So you obviously thought about this a great deal. So what do you think? You don't know. Yeah, I think all of it. All of it. It's to me, they're all important. I'm not sure they're equally important, but I think they probably are more or less equally important. And I guess my message is that there are no magic bullets. Like we can expect to get some new magic bullets, but they're going to be quite restricted and very expensive. So there are no magic bullets in this. We need multiple interventions at many different levels, different elements, and continuous improvement. And we have to have faith, but actually we can show it. This has a cumulative impact. Like, I drive a Toyota. Why do Toyotas make such wonderful cars? The Toyota Corolla is a beautiful, beautiful car. Why is it so good? It's because of the Japanese culture of continuous improvement, and we have to do that for antibiotics stewardship. And I think always we have to think about the metrics of success. What does success look like? And I'll come back to what does success look like towards the end. And if you can't measure it, you can't manage it, you can't improve it. So what I'd like to do is just briefly go around this clock and just highlight a few things to illustrate what I think are important. And I'll take it mostly from the veterinary world because I know that better, but I don't think it's any different in the medical world. And so the first one is clinical guidelines. These are complex because in medicine, you really need clinical guidelines in community practice, in long-term care, in pediatric medicine, in daycare centers, in hospitals, in ICU, in dentistry that you've forgotten about, in surgery. Now, each of these have their own particular uses of antibiotics. Each of these have their own appropriate uses of antibiotics. And each of these needs clinical guidelines. And that's a lot of work to do. And you think, well, gosh, that's tough. Can't be as tough in the veterinary world. Well, I'm afraid it is, because we've got companion animals and horses and pigs, and we've got different types of cows, dairy cows and beef cows, and poultry and fish and bees. If you want to shut down a stewardship conference in Canada, you just say, well, what about bees? But I think also wallabies and quokkas and duck-billed platypuses and all that. And developing clinical guidelines is a really intensive process, and it's sometimes an exhausting process. You need to understand current practices, you need to understand where the overuse is, you need to understand what you think is appropriate use and incorrect use, you need to link this to susceptibility data, and it's whatever the value is, and to risk of use and not use, and so on. This is the Canadian Veterinary Medical Association Expert Advisory Group. Probably like Canada, these people have been assembled from all across the country, country which is 4,000 miles across, great expense to bring 50 or 60 experts together to start to work on guidelines and so on, and start to co-opt people to join them in the guidelines, and then eventually validate them and publish them and so on. It's a lot of work. And once you've got the guidelines, you think your job is over, but no, it's just started, because implementing them takes considerable effort, and it's often the bit that's neglected because you think everybody's going to read them, and no, they're not. And the challenges are then to evaluate uptake, to promote uptake, and to update them periodically. This is a study of, these are the Danish Small Animal Veterinary Association guidelines, which are adopted from the Swedes, and I think they're really good. They have guidelines for urinary tract infection, and this was a study of the use of guidelines. So people who were using guidelines tended to follow them. They used amoxicillin and TMS as first line. People who didn't, tended not to follow them and stayed with Clavamox. Interestingly here, this is TMS, trimethoprim sulfur, which is just not available in Denmark, so it's not being used. So guidelines do have an effect. When you study the uptake of guidelines, it's often not that great, but you can see an impact, particularly if people are pushing guidelines at a national level. Infection control. In the veterinary world, in the last 5 or 6, 7 years, there's been a huge surge of multi-drug resistant Staphylococcus pseudointermedius in dogs. This is like the dog MRSA. And there have been several clones which have just worked their way quickly around the world. It's not such a problem, I think, in Australia, but it's certainly a problem in many other parts of the world. And if you look at the risk factors for MRSP, I have never seen an odds ratio of over 100 as a risk factor for an infection. And the risk is hospitalization, or even being in a vet clinic. There's a risk to picking up MRSP. So infection control here has got to be huge. And just in case you think that's just veterinary world, I'll show you another slide. This is a slide of somebody who's concerned about infection control in small animal clinics in Ontario. and they set up video cameras in 50 clinics and just videoed what people did in terms of hand washing. And if they did wash their hands, guess what the median time for hand washing with soap was? Huh? It was 2 seconds. But I think that's not unique to the veterinary world. If you look what happened in MRSA in United Kingdom with voluntary control, nothing really happened until mandatory control came in, and it just sort of reduced dramatically. So in some ways, AMR is an infection control issue. And certainly you can document it. I've just sort of showed you some of the data. MRSA may be easy compared to ESBL carriage of E. coli. And we can start screening based on risk factors and cost benefit. This was a study of the waste of airplanes coming from different places. This is metagenomic. It was resistance genes from different countries. These were countries arriving in Denmark from North America, and these were planes arriving in Denmark from South Asia. And you can see, again, the differences there. Clinical microbiology is another important element in stewardship. I think it's underused, particularly in the veterinary world, maybe, but I think generally it's a critical resource. I think it's an area for huge development. We've got cost and timeliness issues, which I think have limited its use. I think there's still global and national standardization issues. I think it's potentially really important if we move to much more de-escalation and much more kind of infection control. Some countries have mandatory reporting of resistant organisms and genes. We need a lot more point-of-care testing that's potentially going to be the game changer. 5-second, 5-minute test. There's a potential huge link to infection control. And if we do develop more and more narrow-spectrum antibiotics, such as, say, the one for Neisseria gonorrhea, maybe it will be used for targeted therapy. And I think there's a huge role here for innovation, as O'Neill report said. And I think, in some ways, I don't think the diagnostic labs, particularly in the vet world, have really stepped up to the plate on stewardship yet. It's coming, but there's big issues which need to be addressed. In Holland and France, veterinarians are required, if they're using a critically important antibiotic like a third-generation cephalosporin or fluoroquinolone, to do culture and sensitivity. It's been widely welcomed there for various reasons, and it's resulted in a marked reduction of critically important antibiotic use. Resistance and use surveillance is part of the stewardship process. I'll talk a bit about resistance surveillance. It's challenging, it's expensive, it's important. And the challenge, I think, is to prioritize because it's expensive. In Canada, we have an integrated resistance surveillance system, which is kind of recently just kind of formed out of several different elements. And we have key endemic human pathogens that are monitored, strep pneumoniae, strep pyogenes, Neisseria, and so on. There's a separate kind of element to that of pathogens of special interest and resistance of special concern. There's a kind of the old nosocomial system, the Acinetobacter, Enterococcus, and so on. We have also an integrated One Health surveillance system based on indicator bacteria at slaughter or of food animals or at retail, and involves Salmonella, E. coli, and Campylobacter. I think the issues of resistance surveillance is, should it be active, should it be passive, or maybe both? Should it be regional? Should it be national? Should some be reportable? And who would you actually report to, and so on. So we have three elements here. I think Aura has the top two. There's a very famous study in Canada based on the Canadian Integrated Program on Antimicrobial Resistance Surveillance, CPARS, where we monitor Salmonella, E. coli, Campylobacter in humans and in animals, in food animals, at retail, in supermarkets, in a sort of national program. And this was ceftiofur resistance or ceftriaxone resistance in chicken isolates. So this is percentage resistance here, 60%, and it was also found at the same time that a lot of resistant Heidelberg in humans were also resistant. And there was a beautiful link, because once this was realized, there was a voluntary withdrawal. It dropped off in chickens, it dropped off in humans. They tried to sneak it under the radar to just do a little bit of still ceftiofur, and up it went, and eventually it became so obviously linked together that the chicken industry made a voluntary ban. This photograph is going to be in every medical textbook for the next 30 years, I think. It's famous data, and had a huge impact in Canada. Probably the biggest impact on antimicrobial resistance issues in agriculture that we had. And this was the chairman of the Chicken Farmers of Canada explaining on national television why MDR pathogens are isolated from chickens at retail. Perhaps you don't quite get the deer in the headlights look on his face, but this had a huge impact in the country. And is an example of the effect of media and the effectiveness of media in driving change. In terms of use surveillance, I think the challenge is always on reducing use, and resistance follows use. And theoretically, anyway, use is easier to measure than resistance. And Mark showed a slide of sort of linear relationship. This is a slide of indicated E. coli with the sort of resistance up here and average antimicrobial ranking here. So the more you use, the more resistance you see. And we've been quite taken in Canada by benchmarking of animal antimicrobial use. This is quantities of active ingredient per kilogram of animals. There's Cyprus here. Spain is always kind of bad, and Norway up here. Canada's sort of here and doesn't like it. And so they say, look, a Canadian Holstein cow is actually heavier than a British Friesian. The chickens in Canada are I don't know, lighter than the chickens in Holland and so on. So if you kind of fudge the numbers, you can bring it up a bit, but it still doesn't look that great. But I think benchmarking may be much more powerful than guidelines in changing prescribing behavior. And I think that's quite well recognized, whether it's in the form of targets or more particularly just giving people a printout of their relative use, or best peer-to-peer assessment and peer-to-peer discussion with feedback on why are you using twice as much as everybody else. This is the Dutch approach to benchmarking. They've targeted and achieved a 70% reduction in food animal use. This is the average daily dose per year on different farms. And so these are the kind of the average farms, and then these are the outliers, the people who are using a lot more antimicrobial than their neighbors. And they've linked these into kind of red, orange and green. Green is okay. Red, you need to take immediate measures. Orange is, you need to start looking at what you're doing. And they can bring this down to a veterinary benchmark, so every veterinarian is benchmarked. Every, a report on every veterinarian in the country is available on antibiotic use. And, maybe it's time to retire or whatever. You need to do something about that. And farms also get reports of where they fit. That's the Dutch kind of search and destroy approach, but it's dramatic, and it shows what potentially can be done. I think increasingly people are using practice software to look at antimicrobial use. This was a study in the UK of 1.5 million dogs and the use of antibiotics in different practices, dogs and cats, and you can clearly see differences. The nicest study I've seen was in the US, which was a study of 7 million dogs based on practice software by corporate practices on use. And so I think the potential for using big data and the potential for benchmarking or identifying kind of outliers and issues is quite great, but obviously all these things take time to develop. And I think benchmarking is useful. I think numbers do have limitations. I mean, you can't just assess appropriateness from numbers. You need to know the circumstances. Numbers can be gamed as well, and so you need to watch that. But I think there's general value in knowing what people do and providing feedback. And this was antibiotic use in people in Australia and Canada, so we see we're much better. Pharmacokinetics and pharmacodynamics, I'm not going to spend much time talking about them, but it's critical. Like, antibiotics work differently. There's time-dependent antibiotics, concentration-dependent antibiotics. They're secreted differently in different places. We need to understand that, and most people do. I don't want to go into details on it, but knowing the nature of the drug, we can use them better than we do often, whether we use them locally, systemically, and so on. And this was a study also of dosing, which kind of links to pharmacokinetics. This was antimicrobial selection and dosing and treatment of wounds in horses in the UK. This is kind of appropriate dose. This is different drugs, and you can see, particularly for the older drugs, like oxytetracycline and penicillin, the dose rates are just all over the place. We obviously didn't sell enough copies of the book I edited, but it really is, it's in some ways shocking. Regulations. These are important. There have been major changes in the regulations in food animals in the United States and Canada. In Canada, it's taking place December the 1st, 2018. So next month. So that's, and it's taken longer than it should have done, but it's a complicated process to change regulations. But that really is 50 years after Swan. It's amazing. And in general, I mean, there are different approaches to regulation. I think I tend to be the kind of puritanical, command and control, get the regulations tight. Governments don't like regulation. They don't like making laws. Making laws is a complicated process. You have to do lots of consultation. You have to make sure the lawyers understand it, it's written correctly, and then you have to employ inspectors to comply. And it takes a long time, and we have elections, and the laws go off the books and things like that. So the Treasury Board of Canada, which must have a lot of wisdom, prefers a kind of a more informal, flexible approach. So somewhere in there, they say, look, fiscal instruments are important. A carbon tax may be, an effective way to reduce carbon. Or a tax on antibiotics, maybe, who knows. Codes and standards. So industries, veterinary practices, veterinarians, MDs, developing codes and standards, having voluntary initiatives, promotion, information, education, moral suasion, consultation. These are forms of regulation which may be much more powerful than laws. And in Canada, the market has had a dramatic effect on reducing antibiotic use in food animals. The chicken farmers, they were on national television, they were humiliated. They are very, very, very responsible about antimicrobial use in a voluntary basis with their membership. The membership don't get to sell chickens if they don't comply, so it works. McDonald's have been, other major food suppliers in the US have been very influential in making change. So that's not regulation. And then lastly, education and compliance, or nearly lastly. I think the message is out there. I went on Google Images and I didn't really know what to select because there's thousands of images, exhorting the public, exhorting MDs, exhorting veterinarians to do better, and it works. I mean, people have shown that these sort of posters work. Nothing's 100%, but they improve things. And then leadership and coordination, I think is huge, both kind of locally at a practice level, nationally, globally. The whole issue of governance, I think, is critical. NCAS, I think, is showing leadership in the Australian context and coordination. In Canada, the Public Health Agency of Canada, to me, continually shirk their responsibilities on leadership. They say, well, it's a disseminated model. It's got multi-stakeholder. The public, the people who demand antibiotics, the stakeholders, and so on. But that's not coordination. That's not leadership. It's quite the opposite. But this is a critical issue. So I guess my final sort of slides are, I don't think there are any magic bullets. I don't think there are any magic bullets coming, or there are a few, but they're not going to be readily available. I think we need to take a multiple intervention, continuous improvement approach to stewardship based on the different elements that there are, all of which are important. And it's an approach of accepting responsibility, trying to reduce, always refining, trying to replace, and always reviewing. It's a Toyota approach to manufacturing. So I guess my last question to you is what are the metrics of success? How do we measure it? How do we know we've done it? When will we know we've got it? How will we know we've done that? You don't know? There may be an element of faith in success but any other metrics of success? I think actually it's all of the above. Like all of the above are involved in stewardship. So the development of clinical guidelines, to me, is a measure of success. We've got clinical guidelines. Whether they're adopted as a measure of success. Having better infection control, like hand washing Australia, is a success. It's had a measurable success. Better clinical microbiology, better use of it, alternate to rapid diagnostic systems is a measure of success. I think all of these things can be used as measures of success. I think they're all documentable. So thank you.